All right, good morning, everybody. Sorry for the delay. So my name is Nick Carayannopoulos, and today we're talking about damage control orthopedics and temporary fixation of pelvic fracture in polytrauma patient. Here's our objectives for today. So just to get started, I'm going to briefly mention the case that prompted me to choose this topic. Quickly show you one piece of relevant imaging, and we'll move on and come back to it at the end to kind of cap everything off. So we had a 65-year-old male with a largely unknown medical history presented to the ED following a suspected train accident. He had largely unknown history, though he did admit to some fentanyl use before the incident. And overall, other than that, he couldn't really tell us much. His memory of the whole thing was a little bit spotty. So here's the imaging, and we'll come back to it in a little bit. So just to give some background on damage control surgery generally, we all know from having it drilled into our skulls over the course of medical school and beyond that when you're dealing with an acute medical emergency, whether it's cardiac arrest, anaphylaxis, or trauma, the first step should always be to take care of the ABCs. So in the context of damage control surgery for trauma patients, with some exceptions, the focus most often rests with the C, and more specifically in controlling hemorrhage. So in 1908, Pringle noticed that sometimes in trauma patients, definitive hemorrhage control wasn't really possible. And so abdominal packing was the best option to prevent more serious outcomes. And he obviously also famous for, inventing the Pringle maneuver for hemorrhage control. And decades later, Feliciano et al. Examined a similar principle with perihepatic packing as a temporizing measure in hepatic trauma patients. And they noticed a good survival in a kind of small cohort. And that kind of led to more studies in the following years to corroborate the finding. So one of these studies was Talbot et al. In 1992, and they examined temporizing measures in non-hepatic injuries in patients displaying the lethal triad after a trauma, so hypothermia, acidosis, and coagulopathy, which showed some preliminary increases in survival to discharge, which led to further studies like Rotondo et al. The following year, who demonstrated increased survival in what they called maximally injured patients, who displayed one or more vascular injuries and two or more visceral injuries when using temporizing laparotomy procedures initially, as opposed to just going right to definitive treatment. The study is also the first time the phrase damage control was formally used. So at the highest level, damage control surgery is a sequence of three objectives. First is expeditious control of hemorrhage and contamination without reconstruction. Second, resuscitation and correction of physiologic derangement to the best of your ability. And third is to lead into planned reoperation and removal of hardware/temporizing measures and move on to definitive repair. And so all these principles were developed in the context of abdominal trauma. They were obviously rapidly adopted and modified to fit the needs of other trauma subspecialties like orthopedics and thoracic surgery. So Scalia et al. Was one of the earliest studies to examine the principles of damage control surgery in orthopedics, and they looked at the use of external fixation for femur fractures in polytrauma patients as compared to just immediate IM nailing. They found significantly shorter OR times, which makes sense considering the less complicated nature of the procedure, with a median OR time of 35 minutes as opposed to 135 minutes in the IM nail, and significantly decreased average estimated blood loss, about a quarter in XFix as compared.
8.
Okay, well, she usually gets here around 8:15.
Yeah.
I'm just going for a short walk and I'll
Okay.
be back by then. So I'll speak to her about
A
it.
quarter of that's in the IM nail patients.
I don't know what
Dr. Bo, can you mute your
Yeah.
microphone?
That may not be for mold. I don't know.
And decreased average estimated blood loss at about 90 mLs versus 400 in the XFix as compared to the IM nail group, which is obviously a pretty useful finding when it comes to dealing with these polytrauma patients. So before the advent of the more formalized damage control surgery protocols, orthopedic trauma was managed using the philosophy of early total care. Evidence at the time showed that delaying measures like intramedullary nailing for femur fractures for more than 36 to 48 hours in a critically injured patient was associated with longer ICU stays and increased rates of other hospital complications like ARDS and pneumonia. Patients were effectively deemed too sick to not operate on. But as damage control surgery developed, it was observed that this push for rapid definitive treatment often led to under-resuscitated patients that had then worse outcomes. So over time, the early total care or ETC model was phased out in favor of the damage control model, which I'm just going to call it DCO from now on, where vitals and labs like pH, urine output, coags, lactate, and base deficit, that kind of thing, were monitored until the patient was stable enough to undergo definitive treatment, which oftentimes, when managed appropriately, could still be done within that 36 to 48-hour window. One of the major reasons for the observed improvement in outcomes of the DCO model versus the TC was accounting for the second hit phenomenon. So beyond simply resuscitating and stabilizing a patient properly after trauma, surgeons also take into account the amount of stress the patient has already undergone when they experience the trauma, in addition to what they might experience if they undergo a long surgery. There are controlled inflammatory cascades that, in response to trauma, are often helpful from recovering from injury, but in the case of more serious trauma, a more widespread systemic inflammatory response can develop and lead to things like multi-organ systems failure, ARDS, again, decreased protection against infection, and ultimately death. As a result, in cases of major trauma, it's often important to weigh the benefit of definitive treatment against the potential cost of prolonged surgery to compounding that inflammatory response in a polytrauma patient. This is just a good diagram that I found when I was going over everything that shows the kind of acute inflammatory window, that 2 to 4 day window after a trauma, where you want to, make sure you don't compound the inflammatory response with the second hit of prolonged procedure. So what are the actual staging criteria when deciding to do damage control versus definitive treatment? Earlier, I mentioned that they had defined a maximally injured patient as having, 1 vascular injury and 2 visceral injuries. That's certainly not specific enough to guide a lot of clinical practice. So there's still a lot of debate about the specifics, but some of the criteria that are assessed initially include things like injury severity scores, Glasgow Coma Scale, presence hypothermia, acidosis, and specific radiologic findings like pulmonary contusions or the presence of bilateral femur fractures, amongst other things. And certain lab values are also super useful. High levels of inflammatory markers are often looked at, like IL-6 on initial eval, along with the previously mentioned factors. But alongside that, there are also 3 lab values that are of pretty significant importance, which are the high lactate, base deficit, and pH. These are often monitored to determine when adequate stabilization has been achieved and to help time definitive treatment. So during the window in which the second hit is a risk of definitive treatment, there's still some injuries that get to be surgically treated, at least in some fashion. They can't just be left alone. Oftentimes, these life-threatening injuries pose some sort of increased risk of further vascular insult and include things like compartment syndrome, spine fractures, amputations, unstable pelvic fractures, etc. In these cases, DCO measures like X-fix or skeletal traction can be used to reduce physiologic derangement while still being less stressful to the patient than an invasive definitive repair, or a more prolonged, I should say. And then as important as determining whether a damage control approach should be used in the first place is then deciding when to proceed with definitive treatment. As you might suspect, type of injury has a lot to do with when it can be treated after a polytrauma. A lot of fractures can be managed with acute, can manage after the acute inflammatory window is passed, usually between 2 to 5 days, with minimal other intervention. So for example, an unstable patient with a humerus fracture can be left in a splint until they're really truly stabilized. But some injuries require further delay even after temporizing measures have been undertaken to ensure the best outcomes. When meeting a lot of the previously mentioned criteria, pelvic, femur, and tibial fractures specifically are postponed a lot longer than that 2 to 5 days a lot of the time. Pelvic and tibial fractures, ideally 7 to 10 days after insult, and femur fractures can be delayed upwards of 3 weeks. There's also a more recent concept called early appropriate care, as juxtaposed with early total care. That tries to balance the benefits of early total care with those of DCO. When patients show a dramatic improvement to damage control measures, oftentimes a definitive treatment can still be carried out within that optimal 36 to 48-hour window. But if it can't, then there's at least set up to be stabilized. And then you can follow the previously mentioned 7 to 10 or 3 week protocol. And it's just another flow chart that I found for the decision-making process when it comes to deciding whether to use damage control measures. So I just want to briefly go over these, how these principles are applied in pelvic fractures. Most pelvic fractures are fairly high energy, often associated with multi-system injury, and require interdisciplinary management. Patients with pelvic fractures, early mortality is often due to uncontrolled abdominal venous hemorrhage from the venous plexus, and late mortality is due to multi-organ failure from a variety of things like inflammatory cascades or sepsis. It's believed that the soft tissue damage associated with these fractures actually can directly contribute to the excessive inflammatory cascade, and is part of why the pelvic fractures have a longer delay between DCO and definitive repair as opposed to other types of fractures. In keeping with the principles of damage control surgery, controlling early hemorrhage is the first priority and is often achieved by applying pelvic binders, giving them volume replacement, use of drugs like TXA to control bleeding, and interventions like embolization. Patients that are still found to be in extremis after these initial measures are taken and then managed with DCO intervention, most commonly X-fix of the pelvis. So to get back to the case I mentioned at the start, we had a 65-year-old man suspected of being hit by a train. Most of his imaging was relatively unconcerning, but once we got to the pelvic X-ray, it was pretty clear that he had an open book fracture along with significantly accommodated fracture of the sacrum. Now, his vitals were also concerning for shock due to his soft blood pressure, tachycardia, and on physical exam, he had widely fluctuating GCS scores, inability to move his lower extremities, non-palpable right dorsalis pedis pulse, and a variety of abrasions and contusions, though he didn't have any notable sensory deficits, at least on initial evaluation. His labs were also concerning. He had low hemoglobin, low hematocrit, increased lactate. He also had increased venous lactic acid and decreased PCO2, which might indicate some level of acidosis, which, like I said, the acidosis with low pH and high lactate are two of the important lab values when trying to determine if someone is stable enough to do definitive treatment or if you want to go into DCO. This is just the X-ray of his pelvis after he put the pelvic binder on. So using the patient to summarize the principles that I just mentioned, he came in with a broken pelvis after a polytrauma. Once ABCs were taken care of, he was put into a pelvic binder. And a further exam showed signs of hemodynamic instability that was persisting and labs were concerning. He was taken to the OR for embolization to control the bleeding, which is stage 1 of DCO, expeditious control of hemorrhage. He then received the next fix of the pelvis to reduce physiologic derangement, stage 2, and then he was monitored until he could undergo definitive repair and removal of hardware. I believe he actually underwent a ORIF of the pelvis. It's just the best X-ray I could find of his pelvis after the X-fix. And then these are my sources. And thank you very much.
So can you go through so you're in the emergency room, this patient comes in, everyone's running around, he's unstable. So what would you suggest if you had to put it a few steps simply? Like, what's your protocol? I know you put it up, but can you go through it step by step? Just simply, it doesn't have to be very detailed.
Yeah, well, I mean, I guess we would first want to put it, so if he just comes in with no interventions already done, I guess you would first want to check to make sure, do physical exams, see if he has any instability. They've likely found instability in his pelvis, so they would want to put on the pelvic binder. Going to make sure that, this is assuming he also already took care of his airway and breathing. So,
first thing, exactly. As part of the protocol, there'll be a chest and pelvis X-ray, or there should be. Sometimes they skip on the pelvis X-ray because someone's going to the CT, but pelvis X-ray is part of the ATLS protocol. Once you see it's wide, your best suggestion would be to put a pelvis binder on it, and then you reevaluate the patient. See if sometimes just doing that alone can help them kind of control their pressure a little bit. Now, part of the resuscitation, what else is being given in the emergency room?
Sorry, I missed the last part of the question.
Part of the resuscitation, what else is being given in the emergency room?
He's being given fluids to deal with his hypertension.
And what else? What's better than just fluids?
Probably blood products.
Correct. There's 1 to 1 to 1 ratio of blood products to stabilize. Now, let's say you have the pelvic binder on, CT or X-ray shows it's closed. He got blood products and he's still unstable. What should be the next step?
Maybe you want to do a fast to look for any internal bleeding and see if he needs to have an embolization.
Correct. Well, usually fast is grossly positive with fluid. They don't send you to embolization to take you to the OR for an X-lab. It just depends on a little bit of some of the other findings on CT, if there's that, like chest or abdomen, whatever it is. But yeah, the fast exam is part of the initial workup, so that should be done to see if there's actual fluid in this, because it means something's actually bleeding out. And if he's still unstable, then they go to IR, right? So what happens if, despite IR embolizing a bunch of stuff, the patient is still unstable?
At that point, I'm not sure what you would do after that.
You go to the OR, and depending on some of the findings, that means something is critically wrong somewhere else. Because if it was just the pelvis, typically IR embolization, resuscitation, pelvic binder will help control from our standpoint. So unless someone has other injuries somewhere else, that typically gets you resuscitated, or at least to the ICU, where it can be much more closely. But if there's still instability despite fluids control, and they're the fast, they're going to the OR. But the answer is not, oh, it's an open pelvis, call orthopedics, you need an X-fix immediately. No, there's a kind of a accepted step-by-step protocol of how to manage these kinds of patients, which you went through. But it's helpful for you as an orthopedist to know, because it's not uncommon that between the trauma, or there's some vascular, or the ER attending is down there, everyone's running around saying, call ortho, pelvis is open, we need an X-fix, or needs to go to the OR, when in reality it should follow a certain established protocol. And then usually at the very end is when orthopedics is needed in this, if they're need the pelvis stabilized.
Got it. Thank you.
How long can you keep the binder on? And two, why is the next fix not permanent treatment? Why do you have to do something later? As you said, the next step is reconstruction later.
Well, the X-fix is, I mean, I as far as how long you keep the pelvic binder on, I don't know exactly what the limit is, but usually they keep it on just until they can be taken for some other stabilizing measure. But why you wouldn't want to keep the X-fix as opposed to doing an ORIF? I guess you don't want to just have someone walking around with external hardware on them. I feel like it's probably not ideal, but there's a more specific answer that you're looking for. I'm not entirely sure.
The pelvic binder is usually not more than 48 hours, but you should at 24 try to check the skin, because the limit is the pressure that it puts on the skin. So you want to make sure you're not breaking down or developing ulcers or wounds around it. But usually recommended not more than 48 hours, because complications start to occur. But maybe sooner in someone who has poor biology, older. So you have to, at 24 hours, you want to start kind of checking around the binder. And do use the external fixator as a definitive treatment. It just stays on for 6 to 8 weeks. But that's after 8 weeks, the pins are starting to get loose. It can be used as a definitive and then taken off, depending on the fracture pattern.
Thank you. That makes sense. All right. Thank you very much, everybody.
Our presentation for today.
I think in special circumstances, if you absolutely have to keep the binder on for whatever reason, you can go to the OR and the next fix, or you can even do a bedside. You can do